Thank you all for joining us today. While I wish we were together on campus celebrating our Bates reunion, I am so glad we're able to be connecting here today. I am Emma Sprague. I'm a member of the class of 2010, and I am a Bates trustee. I am so excited to be facilitating a panel with some amazing Bates alumni who will be sharing their stories and insights from working on the front lines as our nation and our globe has taken on COVID-19. Before I kick off the discussion, I'd like to remind us of some logistical items for our program. First, this session is pre-recorded, so there will not be the opportunity for questions and answers at the end. However, if you have any questions while watching, please feel free to send them to alumni@bates.edu, and we will share them with our speakers and get you answers. And you can expect this program will be about 45 minutes long. So now, without further ado, I'd like to welcome our fabulous panelists. We have Kate Drummond Zimmerman, class of 1995.
Hello.
Pete Skelley, class of 1960, also a parent of Jonathan Skelley, class of 1996. And Mariam L, class of 2010.
Hello.
The four of us across our years are celebrating our 10th, 25th, and 60th reunions. Okay, so to kick us off, I would love to get from each of you just a quick introduction of where you live, the nature of your work, and then also, please tell us which dorm you lived in your first year at Bates. Kate, would you kick us off first?
Sure. So I live in Yarmouth, Maine, and I work at Maine Medical Center as an emergency department physician and have been there since I started residency in 2003. So I've been there since then. I also am the Associate State Medical Director for Maine EMS and the Trauma Systems Manager. And so I work with the state in writing our EMS protocols. And the dorm room I was in, or I was in Smith South, I think I was on the second floor, maybe 202.
All right, Mariam.
Hi. So as Emma mentioned, I'm class of 2010. I lived in Smith. I currently live in Seattle, Washington, and I work as a hospitalist, which is a doctor that works primarily in the hospital, taking care of anyone who gets admitted there. And I'm at the University of Washington Medical Center Northwest.
Wonderful. And Pete?
I am a laboratory director of 4 labs in Texas. I am really a clinical biochemist, and I'm a consultant. I help labs get started and make sure they do the right thing according to the FDA and CMS and CDC. And when I first came to Bates, I lived in the second floor of Chase Hall because they didn't have enough rooms for our class members. And the second semester, I lived in 403 Smith South, and I was there for the rest of my time at Bates. 403 Smith South, I remember that, on the corner.
That is so funny, Pete. I was Smith South 403 as well, and now this means that all 4 of us lived in Smith, which is awfully, awfully funny. All right, Kate, I'd like to direct the first question to you. You are working in Maine where there have been a total of something like 2,600 confirmed cases of the coronavirus and a downtrend of active cases over the last week, something like 700, nearly 700 active cases at the end of May and just about 500 active cases today. I'm curious, do these numbers match what you're seeing and feeling? And can you tell us a bit about how Maine has responded to this health crisis?
Yes, so I do think, at least for me clinically, those numbers feel about right. We are seeing less patients in our designated COVID unit in the emergency department, and it feels like our inpatient volume in terms of COVID has decreased. Though I will say that everything else has come back online, and so we're definitely seeing an uptick in our, what we would be seeing in a normal summer season. So Maine has had I think a really well thought out response to the pandemic. The collaboration between CDC, the Department of Health and Human Services, The Department of Public Safety, of which I fall under the Bureau of EMS, have all collaborated to respond to get all tiers of the system together on the same page to be able to, we closed the state, I think moved pretty rapidly, and we're able to really flatten that curve, as a lot of people have talked about. Our CDC kind of director, Dr. Shaw, has held daily kind of public briefings along with members of the other departments in our government. And that's been really great, having kind of consistent information delivered in a way that is easy to digest and respond to. We've also collaborated. We have very close relations with New Hampshire and Vermont in terms of EMS and our medical directors, and we belong on national boards and organizations where we're sharing experiences. So we've been talking to folks in Seattle, when it first came to you guys, and started to really ramp up and tailor and get ready and prepare in our emergency departments and prepare our hospital to receive based on the lessons learned from you. And there are still webinars that are occurring, 3-4 times a week that are free for us to join, where there's collaboration not only across the United States, but across various countries that have been responding to this. So the information is, constantly changing. And, there's not a lot of evidence that we could initially base our treatment and response on. But with the help of the other countries that saw this before us and other places in the United States, Seattle, New York, and places that were hit hard, we're able to learn from their experiences.
That is so neat, and it sounds rather unprecedented for a community that's often fast moving and maybe collaborating not as often, certainly across the country. To another hot topic, Pete, I understand that your lab has been at the forefront of antibody testing. Can you talk to us about the importance of these tests and what you see as promising, as well as any concerns you have about how testing is being handled?
Well, 3 of the 4 labs are presently trying to do COVID testing. And there are actually 2 different tests. There's the antibody test, or the serological test, that tests for the presence of antibody in the blood. And the other test is a molecular diagnostic test. The value of the serological test is that it tells you if the person has any immunity, any antibody that they developed against the COVID testing. You first develop an IgM and you develop an IgG, and that tells you that you have the antibody, and therefore you are quote unquote protected. For how long, we don't know. The molecular testing involves an extraction from the swab removed from the nose to see if the virus particle itself is there. And it's a very complicated test to perform. It's a very dangerous test to perform, because there are a lot of biosafety issues involved. What I heard this morning, somebody told me who's reputable, they heard that the CDC has now come out today they said that the serological test is of no value. And like Kate said, things change every day. And I'm thinking, I don't know why they have come out and said the serological test is of no value. My guess is that the test has problems with accuracy, has problems with specificity. If you're the patient, or if you're the doctor, somebody's taking care of the patient, you want to know for sure if the patient tests positive, the patient, he or she, is really positive. Because one of these kits has like a 40% false positive rate. Or if you find out that you're negative, are you really negative or not? This is a great concern to everybody. It's a concern to me, because I'm thinking, well, we need to give out the right results to our providers to give to their patients. So that's an issue that I'm very concerned about. How the test is performed. Do they use biosafety procedures to protect the employees in the laboratory? They need to be protected when they're handling blood or swabs from patients. And it's a very strict requirements from the FDA and CDC. And how do you handle these specimens? How do you open them up? How do you handle them is very, very important. So those are my concerns about the two different tests used to evaluate the COVID-19 virus, the antibody test and the antigen test.
Great. All right, Mariam, you have been very clear, and I've been awfully lucky as a good friend of yours to be getting your input since the early days of this virus. And you have been very clear about the fact that COVID is not a great equalizer. In fact, COVID-19 has amplified the racial disparities that have always existed in this country. Can you talk to us about the factors that you see driving that disproportionate effect on communities of color and other vulnerable groups?
Yeah, so I think early on in this crisis, people talked about how COVID could impact everyone, and that is true, but I think that it disproportionately impacts people of color for certain reasons. You know, if you look at the numbers, the Hispanic population and the Black population in this country are hugely impacted beyond the white population. For example, in Washington state, I think we have 13% of our population is Hispanic, and 30% of the cases in our state are in the Hispanic population. And that's probably for a couple of different reasons. I think one, and most importantly in a lot of ways, is that there's implicit bias in the healthcare system, that meaning that doctors and other providers treat patients of color differently, whether or not we know we're doing it. I think access to healthcare, both in this crisis and then more chronically, has been an issue. And that plays kind of hand in hand with the fact that many of these groups of color are chronically stressed due to the systemic racism in our country. And that's the so-called weathering phenomenon, meaning that you face racism every single day. It causes stress on your body, and that can lead to development of chronic medical conditions. And then, you know, compounding that with not being able to see doctors, not having health insurance, all of those things can add up to the vulnerability in facing this infection, because we know that patients who have diabetes, high blood pressure, and other chronic medical conditions fare much worse with COVID-19. And then, you know, I think another aspect of this is that many of the essential workers in our country are minorities or other vulnerable groups. And so, you know, the people who are delivering your mail, the people who are, you know, working custodial staff, who are working in the grocery stores, many of those people are minorities or people from other vulnerable groups. And so I think all of those and other reasons have created this disparity. And I think that COVID could be a real opportunity for us to address some of those things, to change our healthcare system, to expand access, expand insurance coverage, and really, you know, address these issues that our country is obviously talking about and suddenly, you know, finally aware of.
Absolutely. Just for the urge to be specific here, is there a specific patient you'd be willing to tell us about who's either shown how these factors play out or given you some perspective on this?
Yeah, so one of the patients that really stuck out to me over the past couple of months working on the COVID unit was a 65-year-old woman who had immigrated to the United States from Ethiopia about 20 years ago as a refugee. And she worked as a custodian at one of the local skilled nursing facilities. And she lived alone. She didn't really have any other places where she could have gotten COVID, but came home one day feeling really achy and with chills, and later developed a cough. Her daughter, who worked as a nursing assistant at one of our other hospitals, brought her in to the emergency department where she tested positive for COVID. And when I first met her, I looked at her and I thought, this woman is going to die. You know, she looked horrible. She was so sick. Her chest x-ray looked horrible. Her labs showed signs of inflammation throughout her body. And I was really worried about her. She got admitted to the hospital, and over the next couple of days, she just continued to look worse. And I think one of the really hard things for me to watch was that she was completely alone. She was stuck in this hospital room without having any visitors. She, didn't speak English very well, and so she really wasn't able to communicate much with the staff. And her daughter was working nights, and so she couldn't see her either, and so she was really isolated. The hospital that I work at was one of the sites for the remdesivir trial, which was recently published, and that's a medication that's been shown to have some effect, hopefully, in COVID. And so this patient was enrolled in that trial. I don't know whether or not she got the drug or not. But over the next couple of days, she started to get a little bit better. And I went from thinking that this poor woman was going to die alone in this hospital in a really unfamiliar environment to discharging her a couple days later back home. So I think that her story spoke to me both about, the vulnerability of patients like her who are working these essential jobs, keeping our healthcare system afloat, and also to the solitude and, the precariousness of this disease.
Absolutely. Well, thank you for sharing that. Kate, in addition to your patients, I was so sorry to hear that you also have a parent who was critically ill. Can you tell us about that and anything that it taught you to have this member of your family be going through this in addition to all your patients?
Yeah, so this was an eye-opening experience and a very difficult experience to go through during this time because, as Mariam alluded to, there are no visitors for patients. And that was the same for me when my father became critically ill. He became critically ill in the middle of April with fevers, chills. He was confused, delirious. His oxygen levels were low. Labs, the inflammatory markers, for that, for the infection, all were elevated, and it very much looked like COVID. And so he was initially hospitalized in my hometown, and then needed to be put on a ventilator and sent to my hospital, Maine Medical Center, which is kind of the tertiary care center for Maine and Eastern New Hampshire. And I'm also his medical power of attorney, so making decisions. And, having your parent ill and trying to advocate for them and not being able to see them and understand fully what's going on. Plus, I cannot look in his chart, right? I am not allowed to look in his chart. So I really depended upon connecting with the doctors and nurses who were taking care of him. And they're taking care of a lot of other patients. There were a lot of sick patients that were there at that time of this pandemic. And, that isolation, not only for the patient, as he recovered and how frustrating it was for him, and getting different, mixed pictures from different staff because he recovered actually quite quickly. Was difficult. And it ended up being anaplasmosis, which is a tick-borne illness, and which I'm thankful for. He had been treated with doxycycline to start with as part of a treatment protocol that was being tested for COVID. And he had 5 negative COVID tests too during this whole thing because they were so convinced that's what it was. But now, as I am working in the emergency department, and I've had to intubate patients that are, suspected COVID patients, and having to call their family members and tell them your loved one is critically ill. You can't, they can't be in here with us. This is what I need to do. Is there anything you want me to say to them before we intubate them? Is, what can we do to help you through this? And I worked at triage today. And triaging patients, and even for non-COVID, right now we have no visitors allowed in the hospital unless there are very specific circumstances where that can happen. And to try to allay the anxiety that causes loved ones who want to advocate for the patient is really difficult, but I can kind of relay, like, I understand what you're going through right now, and I'm really sorry. And these are the things that you can do, and I try to empower them to connect to the care teams. But that, every now and then you get so ingrained in medicine and, what you're doing, and you kind of forget the humanity of it. And I think this has really kind of made people step back and look at the humanity. So.
Oh, absolutely. Pete, you said something to me about how anyone can make a fact that they want or find the fact to prove their point, but that in some cases, this fixation on numbers in this virus has been shielding us from the fact or at least abstracting the fact that these are lives and people and children and parents.
Absolutely. I mean, behind every blood or every swab, behind every single sample, there is a loved one. Somebody belongs to that person, their family, their whoever it is, there's a loved one. I have to keep reminding the young technologists, it's not just a number, it's not just a tube, there's a person behind that. Oh yeah, we know that. Well, I just keep reminding you, handle it very carefully. Don't make mistakes. Don't get the tubes mixed up. Don't give it the wrong number or the wrong value. And people are all human. Everybody makes mistakes, and we have to minimize those mistakes that people might make. One of the concerns that I have down here, I live in a large city. I mean, I think San Antonio is probably the 10th largest city in the country. I'm impressed by the fact that most people here wear their masks. There are a few people who don't want to wear their masks. I just refer to them as knuckleheads. But people need to remind themselves to wear their mask. And I feel that we are all leaders, whether we want to accept that title or not. And if we're a leader, then we have to set an example. We have to wear our mask when we're out. And people who don't want to wear their masks, they're endangering themselves and other people. And I have to tell people in the laboratory who don't want to wear their mask, you have to do this as a requirement. And it's a very important thing that we do the right thing. We just can't assume at a certain date the virus is going to be gone. The virus is going to be around for a long time. And I encourage people to stay informed, stay educated, listen to what Dr. Fauci has to say, because it changes every day. And stay informed. Do not listen to politicians. Listen to the scientific and the medical community. They know what's going on. And I agree exactly with everything that Kate said, that you have to be informed and stay in touch with what's going on. I understand there may be a second spike coming up now in some states or some localities. That's a great concern. It's a great concern to the whole country that we have a second peak in the coronavirus testing. So.
Good advice. Scientists, not politicians on the headlines. I think that's a
Absolutely.
very good universal guidance for all of us.
I mean, scientists may make mistakes, but they acknowledge the mistakes. Things change every day, and I don't know whether this is true or not, that the CDC has recommended that we don't look at the antibody testing. I'd like to know why, and I'm sure it'll probably be in the paper tomorrow.
Right. Okay, I'd like to turn this conversation to thinking about the mental health element of this. This is obviously a vital part of this conversation. Kate, I think you shared with me that psychological distress has more than tripled between 2018 and this spring. Mariam, to start with you, why is this virus especially trying on our mental health?
I think, as Kate mentioned, one of the hardest parts of this is the separation of patients from their families. I think we have not seen this before in, patients who are critically ill in the hospital not being allowed to be with their loved ones. And I think that is just, both in making the medical decisions, but just having someone that you love by your side while you're going through something so difficult. And so I think the impact on families and patients is terrible. I think that there's also a big mental health impact on providers and on people like you all who are sitting at home and trying to avoid getting this virus. I think, from the doctor-patient relationship standpoint, it's been hard to not be able to go in and spend a lot of time with these patients. We're under these restrictions too, where we're basically supposed to limit the amount of time we're in the room with the patients so that we can prevent ourselves from getting the virus. We're also covered in gowns, gloves, blue plastic everywhere. And so we really do lose that kind of human touch that I think a lot of us went into medicine for. And so there's kind of an isolation just, even in the hospital, there's more isolation than we're used to. And then I think, for those of you at home who are trying to avoid getting this virus, rightly so, the isolation can have huge mental health impacts. And I've seen in my own loved ones and other people I know how that's caused more stress. It's exacerbated a lot of mental illness in people across the country. And so I think, remembering to take care of yourself, reaching out to people in the ways that you can, and just, finding value where you can in human connection.
Absolutely. Kate, are there ways in which you're advising your patients and their families to be prioritizing their mental health, things you're doing in your life that Bates alumni should know and be integrating into their tactics as we continue through the next weeks and months?
Yeah, this is, this disease, this pandemic, as Pete alluded to, is we're going to see a second wave of it. And we really have to stay aware and in tune and pace ourselves. We have to build resiliency. We can't become, complacent. And it's really hard to kind of keep your guard up for a long period of time. It's exhausting. And so I think really kind of stepping back and taking time, and though, like I'm homeschooling now. So when I'm not at work, I'm home with my 4th and 5th grader. Last day of school is tomorrow, which is exciting, but is really embracing that and finding the positives in it and spending hopefully quality time exploring, maybe taking time to find new hobbies or rediscover old hobbies that you can do. I think getting out, now we can get out and go for walks. I think getting fresh air and sun is really important. We've been lucky in Maine, unlike, being in a highly densely populated area like New York City where people couldn't leave their apartments or houses. We've been fortunate here, but getting fresh air, exercising, is trying to get out and exercise daily. It has many, many benefits, and making sure that you're eating well, kind of, focus on whole food nutrition as the best you can, and not eating as a means of comfort. So I will say I've done that here and there. And, just talking. Don't be afraid to talk. Don't be afraid to admit that you are sad, that you're scared. Talk to your friends, reach out to people that you really trust, keep those connections, whether it be on the telephone, via, FaceTime or Zoom, or even, I still write and send snail mail to my best friend. You need to stay connected and reach out to your family frequently and check in with them as well.
Absolutely. And on that topic, I would be remiss to not bring up that added energy and emotion and toll that people have been feeling around, as well as inspiration around the activism that's happening around this country against systematic and institutionalized racism. And I just want to note that this event is just the beginning of a broader virtual dialogue and programs that Bates alumni will be able to join in the weeks ahead. So I encourage people listening who have been engaged, who have things to say, to please be on the lookout for these convenings and join the conversation. The Bates community wants and needs your perspectives and participation. And for all these reasons, we need all of us to be taking really good care of ourselves and coming together as a community at key moments. So where I hope you're all having some Bates friend conversations in all of this as well. I know that my Bates FaceTimes have been really key to that connection, and some of the people I feel I can be most honest and open with, and as you said, Kate, admitting really how you're feeling and things you're thinking about. Pete, how are you doing with all this? And are there things you're doing newly? And not to put you on the spot, but you're in a demographic we're being especially careful about.
Well, the thing is that I go out every day to one of my 4 labs, sometimes 2 or 3 labs in the same day. I interact with people all the time. They have questions, they have problems, concerns. So really nothing has changed for me personally. My wife, of course, is staying at home, but she goes out now every morning with a walk around the block, and I see a lot of people out riding their bicycles, people walking with their family members, keeping social distancing, kids running around, which is great. It's wonderful that people are doing these things. And one thing that I've done is I encourage, I've been reading this book here, and can you see it? Epidemics in Society. I recommend it very highly because I didn't know anything at all about the bubonic plague and yellow fever and cholera. And this writer, who's from Yale, does a very good job describing all these epidemics and pandemics. And I've learned a lot about not only the disease and what causes it, but about the fact of history and how it affected countries. And one thing that I'm picking up on what Mariam was talking about, how it affects certain classes of people more than others, seems to me a common thread is that whenever people are living very close to each other, especially like in New York City, or especially in the Grand Army that Napoleon sent off to Russia, you're more prone to getting these diseases, and they have a difficult time practicing social distancing.
So looking at history is so fascinating right now. As I perceive it, there's so much about this disease that we still don't know. And Mariam, I know you've made clear to me that COVID-19 has really forced healthcare providers to practice outside the comfort zone of evidence-based medicine. I'm curious how this affects your day-to-day work.
Yeah, so I think both Kate and Pete have alluded to this a little bit as well, but this is a kind of novel time in medicine because we don't have all this literature to rely upon to make our decisions. There are new studies coming out every day, which is great, but a lot of the decisions that we're making are based on our own individual experiences taking care of COVID patients. And just like Seattle, Seattle was one of the first hit places, and we shared a lot of our kind of lessons learned with other parts of the country. But when we first got hit with COVID, we were getting emails from physicians in Italy telling us what they were going through. And likewise, when New Orleans was hit really hard, we kind of traded back and forth tips on how to take care of these patients. And so it's been this really cool collaboration between doctors across the world. And, I'm even on a Facebook group where people are kind of posting new lessons here and there about, what they learned from their patients. So that's been really cool to see. And I think also in like the scientific literature, there's been a huge output of new studies every day in collaboration across different campuses and, different hospital systems. That's been really inspiring to see. I think on a day-to-day level, I learned from each one of my patients. I remember my first COVID patient I gave too much fluid to, and that caused some complications. And so the next patient I decided I wasn't going to give as much fluid to. And so it's a interesting time to be in medicine. And I think overall I'm encouraged by, just the brilliance and support of the medical community. And I think even though this is not a great time, I think that there are a lot of good things ahead that hopefully will pull us out of this crisis.
Kate, are you as well? I know you spoke about collaboration at the beginning of this panel. Are there specific things that are happening in Maine that really, really feel different?
In terms of the practice of I think we mirror a lot with what Mariam said. We're still kind of figuring out this disease, and even when we think we have it, something changes. And so it's that collaboration and that, sharing that information, emailing back and forth, calling, getting on webinars. And it has, slowly changed, and looking at the testing that's coming out and, the sensitivity and specificity of the testing is really important. And when is somebody, like when you get a nasal swab and it's still positive, but are they really shedding enough virus to infect somebody else? So there's a lot. And I think the way that I practice medicine now is a lot different than I did 4 months ago. And I don't think medicine is ever going to be the same again. I think we are going to have to take a lot of precautions and continue and not let our guard down. I think the good thing is as Mariam said, all the collaboration that's happened like across the hospital systems and kind of where we talk about, private systems, public systems, folks that have been in, financial competition with one another. Some of those walls have been broken down. What I am concerned about is those smaller hospitals where we lost a lot of volume because of suspending elective surgeries. Patients were too scared to come to the hospital. So there were, it's, the number of strokes and heart attacks, people were staying at home and presenting much later in that disease process where there wasn't a lot that we could do to reverse the damage that had been done. And so we need to, so that volume that went down, those smaller hospitals are really, and there are critical access hospitals, and here in a rural state, they're crucial. And so I think we're gonna need to figure out how to support that and really relook at how our entire healthcare system is set up.
Absolutely.
And that was a lot, but
No, fabulous.
but our system needs a lot of work.
Yeah.
In this pulled back the curtains from that, you know, for the system, the disparities that we've been seeing in terms of race and social socioeconomic status.
Yeah, it's a just fascinating moment, and it's really horrifying to hear about those other side effects of people who weren't coming in out of fear of being in the hospital or not feeling that they had capacity for them. You know, exactly to that end, I obviously am not a healthcare professional, and as most of us who aren't, I'm constantly trying to be learning, asking the right questions, reading the right things, especially with this conversation that's so multifaceted and changing, as you have all confirmed, every single day. So at this moment, as we're nearing the end of the panel, I want to open it up. What have I missed? What haven't I been wise enough to ask you today? What else do you feel is important for our alumni to know? And Pete, if you'd like to go first, I'd love to hear from you.
I want to pick up on what Kate just said about people not going to the hospital when they need to, because if they don't, it causes more trouble with them. I would encourage people who are not in the healthcare industry to go to your dentist. If you need to go to your dentist, go to your doctor, go to anybody, because my experience is that they are practicing good biosafety practices. That they wear masks, they wear face shields, they're doing the right thing, they take your temperature when you go in. People should not refrain from going to the emergency room, the hospital, the doctor, the dentist, anybody, because everybody's concerned about this and they're doing their job, and we should not be afraid of this, going in to visit them. I would encourage everybody not to be afraid. And as you said, you know, people are suffering from strokes. You know, they should have gone to the doctor. They should have gone to the hospital. Should have gone to the emergency room. This is very important. Stay educated. Wear your mask. Keep social distancing. Don't let up your guard until Dr. Fauci says so.
It's good to hear all of that reiterated. Mariam, what else do we need to add to this dialogue?
I think one of the scary things about this disease is that we don't know who's going to get sick. We don't know when they're going to get sick. And so it's really hard to predict. And so I would echo what Pete was saying, that, you know, stay cautious, stay on guard. One of the other things that I think is worth thinking about, especially for our more senior alumni and for the younger ones among us, for our parents and our grandparents, is to think about kind of what you would want if you were to get really sick. You know, I think especially with the patients who get critically ill, sometimes things don't go well. And being on a mechanical ventilator is a big thing and can be really stressful on our bodies and can be really scary for our families to witness. And so I think for the more senior citizens among us in the Bates community, thinking about, would you want to be put on a ventilator? Would you want CPR? Would you want these aggressive interventions? Would you want to be enrolled in a clinical trial? What kind of things would you want in your care if you were to get sick? That being said, you know, most of the people who get COVID don't end up on a ventilator. I'm not trying to, you know, to scare everyone, but I think that it's important to think about what kind of care you would want if you were to end up in the hospital with this virus.
Well, I think what I'll do is I'll just get on a plane and fly up to Maine Medical Center and have Kate take care
There
of me.
you go.
There you go.
Kate, thoughts to add?
You know, as I watch the community kind of come together, and then, you know, everything that's going on, just remember to be kind to one another, support one another, understand where people's different viewpoints are coming from. It may be out of fear, out of misinformation, and really try to advocate for your system in your society, and support each other and vote.
Oh, yes.
Oh, brilliant. Well, I want to thank the three of you so much, Kate, Pete, and Mariam, for this conversation. I hope that everyone watching will give our panelists a virtual round of applause for sharing their perspectives and insights with us today. It has been really valuable. Please all continue to be safe, to support one another and our Bobcats on the front lines. And I hope that you will enjoy the rest of today's virtual reunion programs. Happy reunion. Go Bates.